Another thing to examine about the patient, whether it's quickly or whether it's at bedside with some time, is the airway examination. You want to give yourself information about how easily that you're able to ventilate and eventually put in an airway device to help assist oxygenation and ventilation. So the things that we look for, the ability to open the patient's mouth. So we use finger breaths for kind of the a rough estimate. So if the patient's able to open their mouth comfortably, 3 finger breaths, that tells us the mobility of the jaw. The distance from kind of the chin bone to the hyoid bone, that gives us the information of how much room we have along the chin, and then also measurement of 2 finger breaths from the hyoid to the thyroid bone. That gives us kind of the information about where along the neck the vocal cords are likely to be, giving us kind of an estimate in the exterior surface of the neck. And other things that we can do to assess the patient's airway, in addition to the mouth opening, the thyromental distance, is their Mallampati score. And usually that is in line with looking at what the structures are that you're able to see. If you can see full range of the uvula, that's Mallampati 1, all the way to seeing hard palate or a little bit of soft palate. Their neck movement, their ability to pronath or move their the mandible over the maxilla, like a bulldog, that will help us give us the range of mobility of the jaw. And high scores will increase the likelihood that the patient is going to be difficult to intubate and to ventilate. So I think of when you're thinking of this, think of Santa Claus. This is a patient who you've never seen their teeth, you know, big beard, hindering the ability to ventilate. I don't think I've seen him move his neck or his jaw too much, except to say ho, ho, ho. So that might give you an idea when you're thinking in your mind, what is a difficult airway? Think of Santa Claus with his full beard and his belly. The components of the airway exam, things that you can do, assess with time, or you can assess quickly, just talking to the patient and having them open their mouth and saying cheese. Active cardiac conditions. So some of you were saying you would get an EKG if there were any cardiac conditions. What cardiac conditions would you ask about when you're saying, oh, tell me about your cardiac conditions, if that's not in the chart or the patient's not really aware of what they might have? Okay. Previous MI, if they have a pacemaker, great. If they have any known arrhythmias such as AFib, so if they've had a history of MI previous or any coronary artery disease, congestive heart failure, I love it. You guys are hitting the big ones. And any valvular disease. Perfect. And then cardiac conditions that might require workup, such as getting periodic EKGs. So if they have unstable angina that's at rest or comes with activity, if they've had acute myocardial infarction within 3 to 6 months, if they have heart failure that it's decompensated to the point where they have symptoms that are coming on pretty quickly and acutely, if they have significant arrhythmias that are symptomatic or that might cause perfusion issues, and severe valvular disease, and all this can be associated with acute changes in their functional status or other symptoms. Having an MI or acute exacerbation of any of these conditions can cause significant changes in systemic changes. So look for all of that in addition to asking them about their cardiac chest pain or chest pressure. Cardiovascular considerations are their ejection fraction, and hopefully if there's any changes, you have history of a prior ejection fraction, any valvular disease associated with a murmur or not. And oftentimes with dysfunction, systolic dysfunction is where you have decreased ejection fraction from decreased contractility. So they might have a weakened heart muscles, whereas diastolic dysfunction, you might have increased filling pressures with abnormal relaxation. So think about a really stiff heart muscles, and usually there's preserved contractility and ejection fraction. So these are all things that you're thinking about, whether you are, the patient tells you about it or you have a suspicion. So if a patient is having low-risk surgery and they do not have active cardiac conditions, would you do any kind of workup? So we've confirmed no active cardiac conditions. Um, Are there specific conditions, considerations for patients with endocrine problems, hypothyroidism, Cushing's? Are those patients usually not a problem during surgeries? That's a great question. They usually are not unless they are in extremes. So if there are patients who are followed up and they might have levels of their endocrine levels that we have access to, they're compliant with seeing an endocrinologist a few months prior to, and they're kind of aware and up to date about kind of the stability of their medical conditions, then there should be no issues. However, if a patient who is non-compliant or who had recent abnormal labs, then they tend to be more of an issue, and then we might recommend a monitored bed or prolonged recovery. So in this question, so what are some examples of low risk surgeries? When you think of low risk surgery, what are some things that you think of? And I have to say, there's no low risk surgery when the surgery is to you and your loved ones. So I never say low risk surgery in front of my patients because to them it's a big surgery. So great, you guys are saying some limb repair, colonoscopies, GYNs, vitrectomy or eye surgeries, hernias, fistula, PD cath insertions. I love it. You guys are thinking of surgeries that are not going to cause significant cardiovascular changes directly. So here are some surgeries that are considered low risk, intermediate risk, and high risk. And risk of MACE is major adverse cardiac events that can occur within 30 days. So usually if it's low risk anesthesia and minimal changes to their cardiovascular status, then usually it's appropriate to proceed and is considered low risk surgery. Right now in ambulatory surgery centers, it used to be low risk patients getting low risk surgeries. Now, if you're going into the private practice or even academics in ambulatory surgery centers, you're going to see immediate to high risk patients getting low to intermediate risk surgeries. So our frontier is changing. Some of you are asking, if there is a cardiac considerations, what can we do about it if the patient's having kind of active cardiac disease? And that will depend on a discussion with your cardiac colleagues, your cardiac surgery colleagues, recognizing that each of the procedures can come with a recommendation to delay surgery, at least elective surgery, until a certain amount of time. So, and they might need to stay on anticoagulation, dual or otherwise. So the consideration for the intervention will also be the type of surgery that's needed, and when that surgery is needed should also be taken into consideration. So what we have essentially done is walked through the 2004 AHA, American Heart Association, guidelines for what we do for to work a patient up or the outline for it. So step one is the need for emergent non-cardiac surgery. Yes, when we discussed the first patient, we said take them into the OR, ask them a few questions, but really this is not the time to get any lab work, stress tests, etc. If they're not having a emergent surgery, then yes, we do have time to engage more with the patient, the medical chart, and consultants. Are they active? Are they having any active cardiac conditions? Yes, and evaluate them accordingly. But however, if they're not having any cardiac evaluations and it's low risk surgery, we usually can proceed. But if it's not low risk surgery, or even if it is low risk surgery, we're going to ask about the patient's functional status. Patients who have good functional status, and that's reflective of what is actually they're doing in their real life, then they usually should go for their planned surgery or without further interventions. However, if they're having high risk surgery or if they have any high clinical risk factors, we're going to consider their surgical risk and their perioperative risk high. And if we have time, we might get cardiac vascular involved to more optimize them for their surgery. Scales that can be used to discuss this risk, this perioperative risk, is one is called the Revised Cardiac Risk Index, or RCRI. The risk factors that you would consider and the patient would get a point for are history of ischemic heart disease, high risk surgery, those on the list on the right hand side of the chart that we saw, history of congestive heart failure, history of cerebral vascular disease, perioperative treatment with insulin, and preoperative creatinine of higher than zero point 0.2. That's implying or assuming that you have all this information. You might or might not have, depending on how often or how well the patient is followed. But if you know the information, then plugging it into this calculator or this risk index will let you know that this is the risk that, based on the patient's perioperative course, this is the likelihood that they're going to have a major cardiac event within 30 or so days from when they had their surgery. So, of course, if it's higher, you want to do everything you can to minimize this risk without, having the patient wait too long for their surgery. Another risk calculator is called the NSQIP calculator. This is the pediatric one because I thought this was captured more clearly on the slides. It allows you to enter information about your patient, their age, if they have any certain systemic disorders, and what the type of surgery it is. Then it will give you information about the patient's risk. And the good thing about this is that this can be printed out. The risk will look a little bit like this, where you'll have either your risk will be at average, above average, or below average. And it can be printed out like this. You can print it out for yourself, your patients, your surgeons, so that if there's a discussion of you're talking about the risk, that you can send this objectively to anybody who is interested in getting this information on a more granular level. And anticoagulation and surgical bleeding. You always want to weigh the risk and benefits of stopping anticoagulation and how much that will affect surgical bleeding. You want to know the medication, the dose, and what is the indication. Oftentimes I'll ask my patients, what is the indication? Why are you on this medication? And sometimes the answer is, my doctor told me to stay on it. I don't know why I'm taking it. I think I might have had a stroke, I might have had a heart attack, but I'm on it. And what is the risk of stopping the anticoagulation? Is blood transfusion a possibility or a probability? And having a more extensive conversation about the risk and benefits of needing this blood. And if the patient is a Jehovah's Witness, ask in detail about the wishes that are consistent with their faith should any bleeding occur. And these are very important things to discuss several days prior to the surgery, because sometimes these anticoagulants need a certain amount of time to clear the system. So with Jehovah's Witness patients, discussions of cell saver type interventions, yes, that's a great question. And this will also be in line with what the patients individually will accept. Some will accept cell savers on the condition that it's, may not undergo different washes, or there's a certain procedure or processing technique in that it never leaves the body. So various things to make sure that you discuss with the patient, discuss with the perfusionist, to make sure that this is in line with the patient's faith and beliefs. There's charts out there. This is just an example of a chart. If the patient is on a medication such as clopidogrel, what the brand name is, the mechanism of action, and how long you might need to be drug-free prior to elective surgery. And this is a discussion that should be had with the cardiologist, or at least the person who's maintaining the renewal of these medications, and the surgeons. From an anesthesiologist standpoint, it usually is not too much of an issue. We might type in screen cross versus type in screen if the patient is on a certain type of anticoagulation, but this is more for a patient's medical systemic maintenance as well as the acute surgical bleeding. Now, cardiac conditions is often what we consider the most, and this is cardiac, vascular as well, the things that worry us the most. If there's any change or worsening of symptoms, if there's any murmurs that are new, that are ejection murmurs, the ones that radiate in other parts of the body, such as the neck or the back, grade 3 or louder systolic murmurs. And I'm with you oftentimes, like if I'm not in a quiet environment, it's hard for me to hear a murmur, so you really want to, if you're listening for this murmur and the patient has any barriers to getting good exam, skin to skin or skin to stethoscope, quiet, and just in all the quadrants to make sure that you're really listening for these murmurs. If they've had any symptoms that required they go to the ER or had any hospitalizations. In terms of the valvular lesions, the regurgitant valvular lesions are usually better tolerated than stenotic diseases. If there's anything that's severe in terms of the aortic stenosis, then that should be evaluated further. And then for any patients who have any issues with infectious endocarditis, they should have IV or PO antibiotics prior. If you have a patient with a severe aortic stenosis, in terms of your cardiovascular status, what are you trying to maintain? What are your goals in patients with severe aortic stenosis? Okay. Yep. Excuse me. Afterload, maintain cardiac output, normal load to normal afterload. Perfect. So the thing about the stenosis is that you want to make sure that the filling is going to be an issue, right? So if the heart is empty and if the heart is going very quickly, the heart rate is going very quickly, you're not going to be able to generate an ejection fraction or stroke volume that's going to help perfuse at the patient's rate. So you want to absolutely preload the patient, make sure they're hydrated, and make sure that you maintain the patient at a bradycardic to normal systolic rate. You want to give the heart time to fill, and you want to give the heart something to fill with to go through these stenotic lesions. So it's going to be keeping the patient hydrated, get the preload, have the patient bradycardic or at normal sinus rhythm so that the heart has time to eject what's the preload. Excellent, guys. And what the echo tells you is it gives you information from all different angles. So you're looking for dynamically the different heart structures. You're looking at how much the patient is, the heart is able to eject with what it has. So it gives you a lot of good information, especially if you suspect the patient has any cardiac issues. Pacemakers and defibrillators, be aware of the settings and how patient movement and cautery affect the device. This can be movement with, when you give the patient succinylcholine, the patient can have those fasciculations, and that can affect the patient's AICD or pacemaker. The ICDs or defibrillators are often deactivated if there will be manipulation near the device. So if your cautery will go near the device or cross the device, oftentimes the patient's defibrillator and AICD need to be evaluated by an electrophysiologist who can then, work with them to say this is what kind of current might be going through, and these are the things that we can, that might trigger the defibrillator. So let's turn it off. And also have mechanisms on how to defibrillate, because now if you have a patient without a defibrillator, you need to have pads or ways to defibrillate them externally. And then patients who a magnet might be placed on them. Magnets do not always deactivate or set a pacemaker to a certain rate. It depends on the pacemaker, sometimes on the manufacturer. So knowing what it does with a magnet is also valuable information for the pacemaker defibrillator. Having this discussion with the cardiologist and the electrophysiologist. Usually the recommendation is to interrogate pacemakers no more than 12 months outside of their last pacemaker check, and AICDs within 6 months. If they have more recent pacemakers or more or defibrillator checks, that's great. And oftentimes with the advancement of having being able to check over the phone, sometimes patients, if they know that they need it, it might be a matter of the just making a phone call versus being in person. And I have a question about temperature TVP insertion depending on the procedure. Uh, oh, temporary. Yes, yes, depending on the procedure. Yes, that's correct. So for the dual chamber pacemakers and the biventricular ones, the pacemakers in general are on the left hand. You'll feel kind of a bump. Usually pacemakers will be a little smaller than defibrillators. Oftentimes, if I have a patient who doesn't know the exact type of device they have, or if they have a defibrillator, I can tell it's larger when I palpate along where the battery is. Patients with high blood pressure, oftentimes this can be diagnosed, undiagnosed, treated, untreated, on acute from being in a stressful situation, or with a patient like that, usually on a day-to-day basis. So why are you concerned about high blood pressure? And what are the important questions to ask? So you're concerned about in the end organs, the pressure can cause stroke, can eventually cause heart failure, have issues with vision, have a heart attack, kidney disease, and other end organ diseases. So maintaining the patient's blood pressure or helping them to lower their blood pressure in a range that doesn't cause end organ damage is valuable. So if you have a patient who has high pressure on the day of surgery, let's say it's 190 over 100, what are the questions that are important to ask to determine if this is the patient, how the patient lives, versus this is something that you should delve into a little more? Yeah, what is a normal, or have they previously been medicated for their blood pressure? What's normal? Do you check your blood pressure at home? And if they have any symptoms with high blood pressure, and if they have any headache, chest pressure, chest pain. Exactly. So you guys are asking, which is really great, asking about the patient's engagement, how much they know, how much they are aware of their blood pressure, if they're having any symptoms, anything that will give you more information about it. It may cause several end organ damages. Usually severe high blood pressure is determined as systolic blood pressures over 200 and diastolic blood pressures over 110 or 115. Usually for the patients that I see, I'm usually in the Wilmer or the ophthalmic and the outpatient centers. Usually I'll proceed if the patient has a systolic pressure that starts with a 1 and a diastolic pressure that's in the double digits. I'll turn my head a little bit if it's higher, but if the patient is not symptomatic, they're talking to me, I'm having that engagement with them, don't suspect end organ issues, then I'll proceed. There's some literature out there that say to delay surgery until if the blood pressure is greater than 180 systolic and over 110 diastolic. The question you should ask yourself is, delaying the surgery or postponing it, what are you going to do to help get it to a range that is acceptable to proceed with surgery?